Morning students. Today we will see one more neurological disorder, that is Parkinson's disease. So Parkinsonian disorders, these are nothing but a syndrome group of disorders. That means it is a neurological progressive disorder. It refers to the group of diseases that resembles Parkinson's disease in some part of their clinical features. Thus, they may have rest tremors, bradykinesia, rigidity, or postural instability. These are the various simple classification of Parkinsonism, primary and secondary. In primary or neurodegeneration, it may be again divided into atypical Parkinsonism and Parkinson's disease. Coming to the etiological factors, the exact cause of Parkinson's disease are not still understood why this Parkinson's disease occurs in people, and the relatively uniform worldwide prevalence suggests that a single environmental agent is not responsible. There may be multiple interacting risk factors, including genetic susceptibility. Various factors will influence the occurrence of peritoneal disease, like Parkinsonian disease, like age and gender, environmental factors, and genetic factors. So these are we will see what happens in Parkinson's disease. First is this genetic tendency will lead to Parkinson's disease, and this use of caffeine, nicotine, and NSAIDs will have a sort of protection from Parkinson's disease. Sometimes if they are absent may lead to Parkinson's disease, and environmental factors like herbicides, pesticides, and protease, some of the protease inhibitors, and heavy metals, use of well water, chronic use of well water also may lead to Parkinson's disease. So in these are the factors. We will see how this causes pathogenesis. What is a pathogenesis? This protease, due to this protease inhibitors, aggregation of protein takes place, which may lead to cell dysfunction, which may lead to cell death, or due to cell dysfunction also may lead to cell death, or inflammation due to chronic inflammation also may lead to cell death. Then lysosomes are chaperone mediated autophagy, that is some sort of autoimmunity and causing cell death. Then mitochondrial depolarization, cascade also may lead to apoptosis and may lead to cell death, which causes which may lead to aging, that may cause Parkinson's disease. Then what are the clinical features? See, these clinical features in case of Parkinsonian disorders are very slowly and insidious, and often we will attribute to these progressive clinical features to old age by the patients. See, there are three important factors which are the clinical features of Parkinsonian disease. Out of these four clinical features, presence of any three can be diagnosed, can be identified, and the patient can be diagnosed as Parkinson's disease. So we call the three symptoms as these three symptoms are definitive for the diagnosis of Parkinsonian disease. The core more features of Parkinson's disease are tremors, rigidity, akinesia, and postural and gait disturbance. So these are the important clinical features. So tremors, resting tremors. See, when the patient is even sitting also, he will have some sort of tremors like movements. Or pill rolling. Just there will be just pill rolling of the fine motors, the fingers. Then fine motor tremors in 70 to 80% of the cases. This is the common. And rigidity, fog wheel type of rigidity will be there, and lead pipe stiffness. See, if you see lead pipes, they can be bent only to some extent. Like that, lead pipe stiffness will be there in case of Parkinson's disease. And akinesia, what distinguishes it from slowness of movement from other causes is a progressive fatiguing, a decrement in amplitude and speed of repetitive movements such as opening and closing the hand and finger, tapping. Repeatedly, they will cause this repetitive movements like closing and opening of the hand and finger tapping. Then progressive, that is called progressive fatigue, and there is difficulty in initiating movement. The upper limb is usually affected first and is always unilateral for the first years. Initially period, the symptoms may be unilateral, and rapid dexterous movements are impaired, causing difficulty in writing, which is called micrographia, and doing of buttons and zips, for example. See, always they just how we put the buttons and how we open and close the zips, that positions, that sort of movements will be very they may be impaired. And facial immobility gives a mask like resemblance of depression. Facial immobility. Then frequency of spontaneous blinking diminishes, producing a serpentine staring looks, and blinking also will be diminished. Then non-motor symptoms like sleep disturbances, sleep fragmentation, sleep apnea, rapid eye movement behavioral disorder, and restless legs syndrome, daytime sleepiness will be there, and mental changes, dementia in 40 to 48% of the cases, and depression 58% of the cases, in apathy in 50% of the cases, and 44% of the cases will have hallucinations. Then autonomic nervous system dysfunction like constipation, sexual dysfunction, urinary problem, sweating, orthostatic hypotension will be there, and sensory phenomena like pain and dysesthesia. Then natural history of Parkinson's disease, pre-symptomatic stage, and let's see, this is how this progression takes place from first year to 2 years and 2 years to 5 years. This is a scheme. During first year, it is called pre-symptomatic stage. The onset will be loss of nigrostrial cells, due to loss of nigrostrial cells. Then initially patient will have anosmia. This is the first symptoms. And then if this patient is having anosmia, at this time, when it is diagnosed, then treatment may be initiated. So that period up to 3 to 5 years we use the treatment, we prescribe the treatment, that is called honeymoon period. And during 4 to 6 years the symptoms progress, the motor complications may be arised like postural instability, non-motor complications also will be there, like and if during this stage if surgery is done, then sometimes death may occur after few years after surgery, or some cognitive decline may be there. Then these are the stages of Parkinson's disease. So this is stage 1. So where the patient looks absolutely normal, but anosmia and those symptoms will be there. And stage 2 will have the postural changes. Then stage 3 where the gait disturbances will be there. Then in stage 4 which see here in stage 3 the muscular he requires assistance for his movements, and in stage 4 he depends on others for even walking. And in stage 5 last stage you can see how the patient is restricted to wheelchair and he may not be able to move at all. Okay, these are the stages of Parkinson's disease. In stage 1 mild symptoms will be there, tremors on one side and postural changes are observed, and in stage 2 moderate symptoms with facial modifications will be there, and tremors on both sides of the body is observed. In stage 3 progression of disease will be there, in imbalance of body and improper reflexes are observed, and in stage 4 drastic change will be observed where personal assistance is required even in simple tasks. And in stage 5 in advanced stage the symptoms will be very aggressive where hallucinations and spasm occurs during this stage. Okay, so this is the progression of disorders, how in preclinical Parkinson's disease where olfactory loss and behavior disorder, then constipation, anxiety, depression and impaired color vision will be there, and onset of symptoms. See, this occurs up to 10 years, and during 2 years, see, early treated for Parkinson's disease, the patient will be stable like bradykinesia, rigidity, rest tremor, and non-motor symptoms will be there. See, in 5 years advanced stage, motor complications, varying of dyskinesias and gait and balance problems. At 10 years, axial deformities and dysarthria and dysphagia will be there. Non-motor complications up to during 15 years after diagnosis, patient will have cognitive decline and dementia, depression, psychosis, autonomic dysfunction, sleep awake dysregulation will be there. This is the progression of Parkinson's disease. And then coming to the clinical evaluation, most patients respond well to treatment, and there is generally a period of several years in which symptoms are well controlled with relatively little disability. Response to dopaminergic drugs is never lost, but treatment-related fluctuations may develop, which can be limiting, especially for patients with early age or at onset. Then eventually, usually by the mid-70s, late-stage treatment unresponsive features such as cognitive impairment, swallowing difficulty, loss of postural stability and pulse, and he may start to emerge. Then the rate of progression is very variable, with a benign form running over several decades. Usually the course is over 10 to 20 years, death resulting from bronchopneumonia and immobility. Then unified Parkinson's disease is a rating scale given in case of Parkinson's disease. You can just go through it. So this is Parkinson's disease rating scale where the disease data can be filled in the form of a scale or a work sheet. See here, depending on the signs and symptoms, if you just draw a line, if the symptoms are progressive, definitely there will rising sort of graph can be observed. Otherwise, if the symptoms are stable, a straight line will be observed. This is how you have to record depending on the symptoms. Then coming to the diagnosis, and there is no exact laboratory test for diagnosing, but it can be made by recognizing the physical signs and distinguishing idiopathic Parkinson's disease from other Parkinsonian syndromes. Patients with suspected Parkinson's disease should be referred to a specialist without initiation of treatment. And MRI is normal and not necessary in typical cases. Dopamine transporter imaging using SPECT or PET makes use of a radio-labeled ligand binding to dopaminergic terminals to assess the extent of nigrostriatal cell loss. It may occasionally be needed to distinguish Parkinson's disease from other causes of tremors or from drug-induced Parkinsonism, but it cannot discriminate between Parkinson's disease or other akinetic rigid syndromes. Then prognosis, variable. It is variable and depends partly on the age of onset. If symptoms start in middle life, the disease is usually slowly progressive and likely to shorten lifespan because of the complications of immobility and tendency to fall. Onset after 70 is unlikely to shorten life and become severe. And coming to the management, the aims of management are providing symptomatic relief with minimal side effects, reduce functional disability, reduce or delay long-term complications of drug therapy, motor fluctuations and dyskinesias, slow disease progression or due to neuroprotection, and treat non-motor complications. These are the main aims. These are the management, how the therapies will help in Parkinson's disease in decreasing the progression, like levodopa, dopamine and salicylic amantadine and dopamine agonists. These are the acetylcholine inhibitors, how they act. Now we will see. So management of early disease is diagnosis and decision is made whether to treat or not. If the decision is no, then the patient have to be made repeated reviews or periodic reviews. If the decision is yes, evaluate the patient characteristics and degree of disability And depending on this moderate or severe disability and age, if the age is 70 to 75 years or more than 75 years or with significant comorbidity including cognitive impairment is there, then definitely the patient can be started with levodopa. And the symptoms are mild, moderate motor disability and no cognitive impairment is there. Benign dopamine agonist can be given, and mild in motor disability and no cognitive impairment is there. Then begin with MAO-B inhibitors. So here levodopa, when the patient is given levodopa, he will be stable. If patient is stable, continue and review. If there is deterioration even with levodopa, use of levodopa, then OMP1 can be given along with dopamine agonist and MAO-B1. Apomorphine supports can be given even if the symptoms are progressive by the use of these drugs. Then if there is intestinal levodopa, apomorphine support, even with this the symptoms are progressive, then intestinal levodopa can be given. The disease progresses, even surgery is the next option. Then these are the drugs used for drugs used for treating Parkinson's disease, and there are adverse effects also given here. There is a table form for you. You can just go through and see how the drugs are effective, what are the different drugs effective, and what are the side effects or adverse effects of these drugs. Okay. So here current pharmacological therapies symptomatic treatment is levodopa remains the most effective form of treatment, and all patients with Parkinson's disease will eventually need this levodopa. It is combined with dopa decarboxylase inhibitor, benziracide or carbidopa to reduce the peripheral adverse effects like nausea and hypotension. 50 milligrams of levodopa 3 times daily, increasing after 1 week to 100 milligrams 3 times daily is a typical starting dose, and the response is often dramatic. Then management complications of use of long-term levodopa: motor fluctuations due to pulsatile stimulation, loss of response to medication before next dose is the delay in response after dose of levodopa. See, these are the different complications. Then when to whether to use levodopa or not is also given in the table. See, end of dose wearing of loss of presynaptic dopa neurons, and delay onset will be there in absorption and crossing of blood-brain barrier, and dyskinesias, fluctuating levels of dopamine sensitized dopa receptors, unpredictable on and off complications, competition between L-dopa with dietary proteins that cross blood-brain barrier, and delayed gastric emptying, and changes in neuronal firing These are the different complications of Parkinson's disease. Then coming to the dopamine agonist, it may be used in combination with levodopa or as initial monotherapy in younger patients with mild to moderate impairment. Although less efficacious in symptom control than levodopa and generally less well tolerated, dopamine agonists are associated with fewer motor complications over a 5-year period. Non-ergot dopamine agonists like pramipexole and ropinirole or rotigotine via transdermal patch are also used in preference to ergot-derived drugs which may be associated with fibrotic reactions including cardiac valvular fibrosis. Then domperidone is used as an anti-emetic when initiating the dopamine agonist therapy. Other anti-emetics should not be used as they may worsen the symptoms by blocking the central dopamine receptor. So domperidone or peridone, it is the only drug of choice used as anti-emetic. Then other drugs in Parkinson's disease are selegiline 5 to 10 milligrams daily, which reduces the catabolism of dopamine in brain. It has a mild symptomatic effect, and rosagiline is another MAO-B inhibitors. Amantadine, a modest anti-Parkinsonian effect, but is used mainly to improve dyskinesias in advanced disease. Then antimuscarinics like orphanadrine, procyclidine, trihexyphenidyl may help tremor but are rarely used in Parkinson's disease except in younger patients. They have a high propensity to cause confusion and cognitive impairment in older patients. Apomorphine, a potent short-acting dopamine agonist administered subcutaneously by an auto-injector pen as intermittent rescue injection for off periods or by continuous infusion pump also can be given. It is used in advanced Parkinson's disease. Then long-term response to treatment. As the disease progresses, medical therapy for Parkinson's disease becomes more difficult as higher doses of dopamine replacement therapy are required, and response becomes more unpredictable with the development of motor fluctuations and dyskinesia's response to dopaminergic drugs is never lost. And however, approximately 10% of patients per year develop these motor complications in the form of wearing off, dyskinesias and eventually on and off phenomena. Eventually, patients may alternate between the on state with dopamine induced dyskinesias and periods of complete immobility. And management of the motor complications of treatment represents one of the greatest challenges in the management of Parkinson's disease. The strategies include dose fractionation of levodopa, increasing dose frequency, addition of the catechol O-methyl transferase inhibitor entacapone 200 milligrams with each levodopa dose to prolong duration of action. Then slow release of levodopa, avoidance of protein and apomorphine, and deep brain stimulation. These are the long-term response to the treatment. Then deep brain stimulation. It is a stereotactic insertion of electrodes into the brain has proved to be a major therapeutic advance in selected patients with disabling dyskinesias and motor fluctuations not adequately controlled with medical therapy. Targets include the subthalamic nucleus, response similar to levodopa with reduction in dyskinesia. The globus pallidus improves dyskinesia, but levodopa is still required for motor symptoms. The thalamus for tremor only. Dopaminergic drugs can be reduced after deep brain stimulation. There is a trend towards earlier use of deep brain stimulation before motor complications become severe. And there is levodopa intestinal gel infusion in case of advanced stages. Continuous infusion of this gel into the small intestine via a jejunostomy using a patient-operated pump is effective for selected patients with severe motor complications. At present, it is used only when apomorphine and deep brain stimulation are contraindicated, partly because of high cost. Next is tissue transplantation. It is an embryonic mesencephalic dopaminergic cells directly into the glutamine has produced mixed results, but is potentially promising. Research is ongoing to refine the technique, and stem cells and gene therapy approaches are in development. And physiotherapy, occupational therapy and physical aids also can be used for a variety of techniques. External cueing techniques are also they are helpful to used as physical aids. Then coming to the nursing management. The nursing goals for the patients with Parkinson's disease include improving the functional mobility, maintaining independence in performing activities of daily living, achieving optimal bowel elimination, obtaining and maintaining acceptable nutritional status, achieving effective communication and developing positive coping mechanisms. Then the nursing diagnosis. First nursing diagnosis is ineffective airway clearance or inability to clear secretions or obstructions from the respiratory tract to maintain a clear airway related to either Parkinsonian changes in musculature, tracheobronchial obstruction, aspiration, infection or truncal rigidity, bronchospasm, fatigue, increased work of breathing, increased mucus production, thick secretions, and possibly evidenced by dyspnea, tachypnea, bradypnea, bronchospasms, increased breathing effort, use of accessory muscles, increased mucus production, cough with or without productivity, adventitious breath sounds, abnormal arterial blood gases. What are the patient desired outcomes are? Patient will achieve the normalization and ability to maintain patent airways and respiratory status. Patient will achieve and maintain a patent airway. Patient will have clear breath sounds to auscultation and will have respiratory status parameters with optimal air exchange. Patient will be able to cough up secretions and perform coughing and deep breathing exercises. Then nursing interventions are observe patient and assess energy level and endurance and how these affect respiratory status. The rationale for this is energy ability decreases with age in chronic diseases like Parkinson's. disease and assess respiratory status for weight, depth, ease, use of accessory muscles and work of breathing for baseline data and auscultate the lung fields for the presence of any wheeze, crackles, bronchi or decreased breath sounds. Wheezing results from squeezing of air past the narrow airways during expiration which is caused by bronchospasms, edema and obstructive secretions and crackles result from consolidation of leukocytes and fibrin in the lung causing an infection or by fluid accumulation in the lungs. Decreased breath sounds may indicate alveolar collapse with little or to no air exchange in the lung area being auscultated and usually results in very poor ventilation. Then administer oxygen as ordered and monitor oxygen saturation by pulse oximeter to provide supplemental oxygen to benefit the patient and assess the patient for pallor or cyanosis in nail beds or around the mouth may indicate hypoxemia. Monitor patient for cough and production of sputum, noting amount, color, character and patient's ability to expectorate secretions and patient's ability to cough. Mucus color from yellow to green may indicate the presence of infection and tenacious thick secretions require more effort and energy to cough up and remove and may cause obstruction and stasis that may lead to infection. Position patient in high Fowler's or semi-Fowler's position if possible. Promotes maximal lung expansion. Turn the patient every 2 hours which may help in promoting drainage of pulmonary secretions and enhancing ventilation to decrease the potential for atelectasis and administer bronchodilators as ordered to promote relaxation of bronchial smooth muscles to decrease spasm, dilate airways to improve ventilation and maximize air exchange. Okay. So encourage an increase in intake of fluids up to 3 to 4 liters per day which provides hydration and helps to kill the secretions for easier mobilization and removal. Perform postural drainage and percussion as ordered. Postural drainage utilizes gravity to help to raise secretions and clear the sputum. Percussion may assist in the movement of secretions away from bronchial walls and enable patient to cough them up and increase the force of expiration. And some positions may be done to may not be done which are contraindicated in some of the elderly patients. And encourage deep breathing and coughing exercise every 2 hours which assists in lung expansion and helps in dislodgement of secretions for easier expectoration. Suction patient if warranted. The patient may be too weak to or fatigued to expel own secretions. In such case you can suction. And instruct patient to seek help and stop smoking if patient is a smoker. This smoking causes increased mucus and vasoconstriction and increased blood pressure. Okay. So another nursing diagnosis is disturbed thought process in which state in which the individual experiences a disruption in cognitive operations and activities and may be related to Parkinsonian medications, use of medications, incorrect or psychological causes, depression or incorrect belief system, chronic illness, misperceptions, which are possibly evidenced by, one second now. So which are possibly evidenced by inaccurate interpretation of the environment, changes in lifestyle, loss of significant other, egocentricity, distractibility, inappropriate thinking, memory impairment, sorrow, hypervigilance or hypervigilance, chronic illness, insomnia, inability to perform activities as before, abnormal lab studies, uncaring attitude, toxic levels of medications and aclination. Desired outcomes are patient will identify factors that elicit depressive reaction and use techniques that will effectively reduce the amount and frequency of these episodes and patient will be compliant with the therapeutic regimen and that is the interventions are Interventions are assess the patient for depressive behaviors, causative agents, and orient patient to reality as warranted. And depression is common among these patients with Parkinson's disease. Whether it's a reaction to the disorder or related to biochemical abnormality is uncertain. Identify specific problems and allow for the establishment of a plan of care when you assess the patient's behavior. And reality orientation helps the patient to be aware of self and surroundings. Use a non-judgmental attitude toward the patient and actively listen to his feelings and concerns. Establishes a trusting relationship and permits the patient to discuss topics that can help the patient deal with in appropriate ways. Parkinson's disease patients often feel embarrassed, apathetic, bored, and lonely that may be brought about by physical slowness and the great effort that even small tasks require. Encourage and assist the patient in every effort possible to carry out the tasks involved in meeting their own daily needs to remain independent. Then identify patients' medications currently being taken and this can assist with the identification of any misuse of drugs and side effects that may precipitate depressive symptoms. Assess the patient for a potential for suicide and suicidal ideation. Patients who are depressed and who have already thought about a suicide plan are serious and need emergency help. Monitor vital signs every 4 hours and as and when necessary. Antidepressants and other psychoactive medications may result in cardiovascular and cerebrovascular insufficiency. Amantadine can cause psychiatric disturbances, mood changes, and hallucinations. Then another diagnosis is impaired verbal communication, which is nothing but decreased, delayed, or absent ability to receive, process, transmit, or use of symptom of symbols. May be related to physical barrier from hypertonicity from Parkinsonism, rigidity of facial muscles, depression medication, psychological barriers, psychosis, depression, use of medication, psychological barriers, psychosis, decreased circulation to the brain, age-related factors, lack of stimuli. All these are the causes and the evidences or manifestations may be confusion, anxiety, restlessness, flight of ideas, inability to speak, stuttering, impaired articulation, difficulty with phonation, inability to name words, inability to identify objects, difficulty in comprehending communication, and dysclalia, dysarthria, inappropriate verbalization, aphasia, dysphagia, apraxia, slurred, slow, monotonous speech, high-pitched, rapid speech, repetitive speech, and facial muscle rigidity. And desired outcomes are patient will be able to have effective speech and understanding of communication, or will be able to use another method of communication and make needs known. Patient will be able to use assistive devices and techniques to improve their ability to communicate. Patient will be able to speak in an understandable way, possible when necessary, and patient will be able to understand communication. Patient will be able to exhibit minimal frustration and anxiety with speech attempts. Patient will be able to make needs known utilizing non-verbal methods if required. Family will be compliant and supportive of the patient's attempt at communication. Then nursing interventions are assess the patient's ability to speak, language deficit, cognitive or sensory impairment, presence of aphasia, dysarthria, aphonia, dysclalia or apraxia, and the presence of psychosis or another neurological disorders which may affect the speech. And rational speech disorders are present in most of the patients with Parkinson's disease. With this helps to identify the problem of area and speech patterns to help establish a plan of care for the nurse. And instruct patient to make a conscious effort to speak slowly with deliberate attention to what they are speaking. Remind the patient to face the listener. Exaggerate the pronunciation of words. Speak in short sentences and take a few breaths before speaking. This helps establish a clear method of communication and speaking to the patient. Monitor the patient for non-verbal communication such as facial grimacing, smiling, pointing, crying, and so forth. Encourage the use of speech when possible, which indicates that feelings or needs are being expressed when speech is impaired. Excessive numbing, striking out, or non-verbalization clues may be the only method left for the patient to express his discomfort. Then attempt to anticipate the patient's needs to help prevent frustration and anxiety. When communicating with the patient, face patient and maintain eye contact. speaking slowly and enunciating clearly in a moderate or low-pitched manner. Clarity, brevity, and time provided for responses promote the opportunity for a successful speech by allowing the patient time to receive and process the information. Remove competing stimuli and provide a calm, unhurried atmosphere for communication, reduces unnecessary noise and distraction, and allows the patient time to decrease frustration. Use simple direct questions requiring one word answers. Repeat and reword questions if a misunderstanding occurs. This helps to promote self-confidence of the patient who is able to achieve some degree of speech or communication. Provide a small electronic amplifier if necessary, which helps if the patient has difficulty being heard, and encourage patient to control the length and rate of phrases, over articulate words and separate syllables, emphasizing consonants. Helps to promote speech in the presence of disorder. Avoid rushing the patient when struggling to express feelings and thoughts. Impaired verbal communication results in the patient's feelings of isolation, despair, depression, and frustration. Compassion helps to foster a therapeutic relationship and sense of trust and is important for continuing communication. And instruct patient or significant others regarding the need of to use of glasses or hearing aids or dentures. Helps to promote communication with sensory or other deficits. Instruct patient or significant others in the performance of facial muscle exercises such as smiling, frowning, sticking tongue out, moving tongue from side to side, up and down. Promotes facial expressions used to communicate by increasing muscle coordination and tone. Then impaired physical mobility, or that means limitation in the independent purposeful physical movement of the body of one or more extremities, may be related to Parkinson's disease or dementia, inability to bear weight, poor nutrition, perceptual impairment, cognitive impairment, tremors, rigidity, bradykinesia, possibly evidenced by inability to move at will, weakness, inability to bear weight, immobility, gait disturbances, balance and coordination deficits, difficulty in turning, decreased fine and gross motor movement, decreased reaction time, incoordination, jerky movements, swaying, postural disturbances, small shuffling gait. The desired outcomes are patient will maintain functional mobility as long as possible within limitations of disease process. Patient will have few if any complications related to immobility. The desired outcomes are instruct patient with techniques that initiate movement. Rocking from side to side helps to start the leg movement. Instruct patient to get out of the chair by moving to edge of the seat, placing hands on arm supports, bending forward and then rocking to a standing position. Parkinson's disease causes rigidity, tremors, bradykinesia and may result in difficulty getting out of a chair. Teach the patient to concentrate on walking erect and use a wide-based gait. Balance may be adversely affected because of the rigidity of the arms that prevents them from swinging when walking normally. A special walking technique must be learned to offset the shuffling gait and the tendency to lean forward. A conscious effort must be made to swing the arms, raise the feet while walking, and use a heel-toe placement of the feet with long strides. Instruct patient to perform a daily exercise that will increase muscle strength. Walking, riding a stationary bike, swimming and gardening are helpful. Exercise prevents contractures that occur when muscles are not used, improves coordination and dexterity, and reduces muscular rigidity. And adherence to exercise and walking program helps delay the progress of the disease. Teach patient to sit in chairs with backs and arms raised. Use elevated toilet seats or sidebars in the bathroom. Helps with rising from a sitting position and prevent falls. Recommend that sexual relations be planned or when the medication is active. Parkinson's causes bradykinesia which can impair intimacy. Instruct patient to raise the head of the bed and make position changes slowly. Teach patient and to dangle legs a few minutes before standing. Avoid dehydration and maintain adequate dietary salt. These measures will reduce orthostatic hypertension. Refer the patient to a physical therapist. May be helpful in developing an individualized exercise program and can provide instructions to the patient and caregivers on exercising safely. Provide warm baths and massages. This helps to relax muscles and relieve painful muscle spasms that accompany rigidity. Next, imbalanced nutrition less than body requirements. Intake of nutrients insufficient to meet metabolic needs may be related to Parkinsonian changes in musculature, facial rigidity, use of anti-Parkinsonian drugs, inability to take in enough food, decreased level of consciousness, inability to absorb nutrients because of biological or psychological factors from the aging process, possibly evidenced by inadequate food intake, weight loss, absent vowel sounds, decreased peristalsis, muscle mass loss, decreased muscle tone, changes in bowel habits, nausea, abdominal distension, lack of interest in food, fatigue from working or breathing, choking, coughing, rigidity of facial muscles. Desired outcomes are patient will have an adequate nutritional intake with no weight or muscle mass loss. Patient will maintain adequate nutritional status with the use of nutritional support and will experience no complications from support. Patient will show no signs of malnutrition status. The interventions are assess the patient's ability to eat, to provide information regarding factors associated with reduced intake of nutrients. Weigh patients daily on the same scale and same time if possible. Provides information about weight loss or gain and provide an unhurried environment during meal time. Provide the patients with Parkinson's disease may have difficulty in maintaining their weight as eating becomes a very slow process requiring concentration due to a dry mouth from medications and difficulty chewing and swallowing. Monitor weight on a weekly basis to assess whether caloric intake is adequate. Then impaired swallowing or abnormal functioning of the swallowing mechanism associated with deficits in oral, pharyngeal or esophageal structure or function may be related to Parkinson's disease, neuromuscular impairment, dysphagia, possibly evidenced by inability to swallow effectively, choking, aspiration, food remaining in the oral cavity, slow eating, difficulty swallowing, chewing, stiff, mask-like face, choking, drooling, weight loss, facial rigidity, muscle rigidity, tremors and aspiration. Outcomes are patient will be able to swallow effectively with no incidence of aspiration. Patient will be able to eat and swallow normally. Patient will be able to ingest an adequate amount of nutrients without the dangers of aspiration. Patient will be able to follow instructions. Then interventions are evaluate the patient's ability to swallow, extent of paralysis and ability to maintain airflow. Swallowing difficulties and choking are common in Parkinson's disease. Evaluation provides based on information from which to plan interventions for care. Maintain head position and support with head upward elevated at least 30 degrees or more during immediately after feeding. Helps to prevent aspiration, facilitates ability to swallow. Instruct patient to choose sugarless chewing gum as stuck on hard candy. To keep his mouth moist and easy dryness of the mouth is side effect of medications for Parkinson's disease. Place food in the unaffected side of patient's mouth allows for sensory stimulation and taste and may assist to trigger swallowing reflexes. Provide foods that are soft and require little chewing. Provide thickened liquids if possible. Avoid thin liquids. These types of foods are easier to control and decrease potential for choking or aspiration. Administer 2 feedings or enteral alimentation as warranted or ordered. May be required if oral intake is not sufficient. Instruct patient or family to use straw for drinking liquids. Helps strengthen facial oral muscles to decrease the potential for choking. Teach patient to place food in tongue, close the lips and teeth, lift the tongue up and then back and swallow. Encourage the patient to chew first on one side of the mouth and then the other. Proper technique to prevent aspiration. This is the proper technique for prevention of aspiration. And instruct patient to make conscious effort to swallow, which control buildup of saliva. Massage the facial and neck muscles before meals, which can help during meal time. Next, risk for injury or may be related to Parkinson's disease, dementia, lack of awareness of environmental hazards, poor judgment, medications, hallucinations, choking, bradykinesia or akinesia. Risk factors are confusion, disorientation, malnutrition, altered mobility, skin breakdown, agitation, physical discomfort, choking, wounds, falls, wandering, involuntary movements, loss of postural adjustment, loss of balance, loss of arms swinging, movement, difficulty initiating movement, shuffling gait, slowness of movement, orthostatic hypotension, activity intolerance, polypharmacy, hallucinations, tremors, muscle rigidity. Desired outcomes are patient will remain safe from environmental hazards resulting from cognitive impairment. Family will ensure safety precautions are instituted and followed Patient will remain in a safe environment with no complications or injuries obtained. Family will be able to identify and eliminate hazards in the patient's environment. The interventions are assess ambulation and movement, aids in planning of interventions, instruct patient to swing arms and lift heels during ambulation. These actions assist gait and prevent falls. Teach patient to turn in wide arcs to prevent the crossing of one leg over the other which could cause a fall. Remind patient to maintain upright posture and look up when walking. Stooped posture may cause the patient to collide with objects. Instruct a wide waist gait to improve balance. Teach range of motion exercise and stretching can to be performed daily. Exercising increases flexibility and improves strength and balance. Next is ineffective coping related to progressive or chronic disease, limitations imposed by the disease, depression, lack of coping skills, physical or emotional impairment caused by normal aging changes and Parkinsonism, changes in lifestyle, as evidenced by verbalization of inability to cope, inappropriate coping strategies, social withdrawal, irritability, aggressiveness, hostility, changes in communication pattern, inability to ask for help, fatigue, increased illness, poor concentration, decreased problem solving skills, risk taking behaviors, poor self esteem, and insomnia. Desired outcomes are patient will exhibit improvement in emotional well being, patient will use acceptable strategies to cope with problems and will have improved sense of self worth. Patient will be able to access support systems, community resources, or counselors to assist in achieving adequate coping skills. The interventions are provide care for patient using same personnel whenever possible, provides for continuity of care and the establishment of a trusting relationship, provide uninterrupted time to be spent with patient and encourage him to express feelings and concerns, allows patient time to express extreme and powerful emotional feelings, and with discussion, patient can begin to comprehend the personal meaning attached to recent events and develop a reasonable assessment of the situation in order to identify a plan to deal constructively with the situation. Assist patient only when necessary. Offer positive feedback for independent behavior. Dependency on the nurse decreases self-esteem. Encouraging desired behaviors promotes effective coping. Encourage patient to make choices about his care. Reduces helplessness and enhances a sense of self-esteem. Identify expectations from patients for behavior and what consequences will occur if limits are not met. Helps set boundaries for manipulative behavior. Manipulation by the patient reduces sense of insecurity by increasing feeling of power. Then assist patient to identify behavior and accept responsibility for actions. A sense of responsibility needs to be developed before any changes can occur. Identify patient's positive qualities and accomplishments and assist patient to recognize these traits. Patient will have less need for manipulative behavior if self-esteem is increased. Congratulate the patient when he or she uses effective coping strategies. Helps reinforce positive behavior. Encourage patient to utilize community resources, support systems, counselors and family and friends. Helps to maintain effective coping skills. Instruct the patient or family in appropriate coping strategies. Provides knowledge and identifies alternatives to inappropriate behavior. Instruct patient or family regarding need for support groups or counseling. May be required to continue complete appropriate care and enable patients to effectively maintain coping skills. Then deficient knowledge related to lack of knowledge about Parkinson's disease, stigma of disease, difficulty in understanding the disease process, lack of coping skills, cognitive impairment as evidenced by verbalization of patients, verbalization of incorrect information, non-compliant, presence of preventable complications, inability to follow instructions, inappropriate behavior, agitation, depression, withdrawal, apathy and restlessness. Then desired outcomes are patient or family will be able to exhibit an understanding of disease process, medication regimen and treatment plan of care. Patient will be able to accurately verbalize understandings of Parkinsonism and its treatment regimen. Patient will be able to comply with medication regimen and notify the physician if patient experiences untoward side effects. Patient or family will be able to identify and demonstrate safety precautions to prevent injury. Patient or family will be able to identify need for long-term goals and potential for end-to-life decisions to be made. The interventions are Assess patients' understanding of the disease process. Consider the older patient's life experience, which provides a baseline of understanding from which to establish a plan of care. New information can be used the patient's existing knowledge base and life experience. Educate patients or significant others about Parkinson's disease, signs and symptoms, treatment and prevention of complications. Limit the length of teaching sessions and provide a quiet and productive environment for each session. Elderly patients may not be aware of old information and the stigma that was attached to Parkinson's disease and dementia and will require re-education regarding current treatments. Reduction of external stimuli assists with learning and the ability to process new information without distraction. Short sessions allow the patient to learn at own speed and prevent information overload. Prepare patient for surgery as indicated. Surgical options may be required to replenish dopamine, improve dyskinesias and rigidity, or to treat disabling drug-resistant tumors. Advise the patient to take the anti-Parkinsonism drugs on schedule. The patient can adjust the schedule to produce peak effect of the drug when mobility is mostly needed. Instruct patient or significant others regarding medications and need for compliance with dosage, scheduling and physician follow-up. Provides knowledge and facilitates compliance with the treatment regimen. Provides for timely identification of serious adverse side effects from medication regimen to allow the physician to be notified post-discharge from the hospital. And anticholinergic drugs can cause sedation, confusion, and urinary retention. Dopaminergic drugs can cause nausea, anorexia, confusion, psychotic disturbances, and dyskinesia and nightmares. Next intervention is instruct patient regarding side effects of medications and when to notify the physician. Dopamine agonists can cause nausea, vomiting, confusion, hallucination, dyskinesia, and hypotension. And some of MBO inhibitors like selerginine can cause nausea, insomnia, and confusion. Monoamino oxidase inhibitors and can cause nausea, insomnia, and confusion. And amantadine can cause urinary retention, increased intraocular pressure, and confusion. Provide time for questions and concerns to be voiced and answer questions honestly. Give patient or family written materials to refer to later. Provide for correction of misinformation and written materials. Allow for documentation to assist with care once the patient is discharged. Instruct patient or family regarding need for long-term planning and potential for end-of-life care decisions. Disease is chronic and the patient will eventually become severely impaired. Issues that may occur in the future should be discussed to enable patient and family to make informed choices while the patient is capable of understanding the severity of the condition. Next, other nursing care plans that can be applicable are self-care deficits related to tremors and motor disturbances, constipation related to medications, and reduced physical activity. Yes, so these are the detailed nursing care plan for the patient with Parkinson's disease. Girls, I think it's very clear for you. And in next video or next tutorial, we will see some other important topics.